All right, so we have a intimate crowd tonight. Very glad to see it. Thank you all for attending. Huge thank you to all of our physicians who are here for our panel today. And I want to say thank you all for joining us for the inaugural event of our Primary Care Week 2024. So obviously we have more events coming down the pipeline. Hope you take a look at it for all the students. But this is a proud tradition for our Primary Care Week, is having our primary care panel, getting your questions answered. So anyone who's curious about primary care, please feel free to jump into some questions, but we have about 20 of them that were pre-written by people who were curious, who will either be joining us online or joining us today in person. Before we really get going, I do just want to give a shout out to my Vice President, Mr. Joshua Perez, who has been instrumental behind the scenes for coordinating basically all of Primary Care Week. So thank you very much for all of your help, Josh. That being said, I'm going to turn it over to our speakers. We have 5 wonderful physicians who have taken very diverse paths in their primary care experience. And if you could all just take a second to introduce yourselves, that would be fantastic. So with that, I'm going to turn it over to our speakers.
We'll do the mic.
I have the mic. Do you want me to get to go first? I'm in the middle.
So that means
It's kind of weird.
it's gonna make it awkward.
It is awkward being. I'm Beth Polk. Let's see, I've been with Geriatrics since my residency here, and did full scope primary care when I came out of residency, did OB, did inpatient, did all the things. And then over the years that went away, and recently in the past 10 years or so, I've added lifestyle medicine to my practice and became board certified in lifestyle medicine in 2017. I've been adding it to my practice ever since then. And then 2.5 years ago, I transitioned over to the residency program. And so now I have basically a lifestyle medicine only practice where I basically just see people to talk about their lifestyle and goal set and work with people to achieve whatever health goals they want to achieve. And we'll go this way.
Testosterone.
Yeah, I'm Ian Reynolds. I'm an internist and geriatrician. I did my residency training in internal medicine at University of Colorado and geriatric training there as well, and spent some time after graduation in academic internal outpatient medicine, so doing primary care in academic setting, and then transitioned to kind of more hybrid of internal medicine, geriatric, outpatient and inpatient. I've been with Geriatrics now for going on 4 years in sort of a hybrid role, doing consultative work, doing have a small primary care panel, and doing some dementia care as well. So it's been my path thus far.
Dr. Marcus Speaker, I'm the Associate Chief Medical Information Officer at Geriatrics Clinic. Family medicine trained here at Geriatrics a long time ago. Here since 2001, so long time. I'm out of residency. I did a medical informatics fellowship here at Geriatrics. It was one of the first in the nation, and then stayed on as junior faculty, and then faculty helped with our Epic EMR implementation back in 2008 to 2010. Did conversion of our old EHR, and then continued to help improve efficiency, improve use with the EHR, and so slowly just kind of moved up the ranks here. So great field. 2015, I picked up my board certification in clinical informatics, and recertifying this year.
Hi, I'm Karen Perkins. I did my residency training in Baltimore, Maryland, and then I also did an additional year in obstetrics. So I did an OB fellowship, practice there as part of the family medicine faculty, because that's one of the easier ways to continue to do full scope family medicine and do obstetrics for a while before we moved to Roanoke roughly 13 years ago. And then I was part of our family medicine faculty practicing full scope family medicine up until the end of 2022, when I transitioned over to working in ED observation. So I'm actually now part of the emergency medicine department, and I supervise a service that is about 25 patients who in theory are there for 8 to 48 hours with observation diagnoses, and I work with the ACPs on a regular basis. So all hospital-based medicine. But most recently, my husband and my family and I returned from a year abroad in New Zealand, where I practiced as a general practitioner there, doing outpatient medicine with the Kiwis.
I'm Bree Beach. I am one of the associate program directors of the family medicine residency program here. I did my residency training here at Carillion as well, and then I went down to Virginia Tech, VCOM, to do a primary care sports medicine fellowship. So worked for the year down there with Virginia Tech athletes and teaching at VCOM, and then came back up here to join faculty. So I do inpatient, outpatient. I'm an EO, so I do a lot of our osteopathic manipulation curriculum as well, and sports medicine wise as far as procedures for teaching the residents, ultrasound guided procedures, MSK exams, that sort of, and some sideline coverage around here as well.
So thank you all for the introductions, and thank you all again for being here. So to get started off, pretty basic question is going to be, what does your day-to-day job look like? And if you work with patients, how do those patient interactions differ? What makes your specialty or subspecialty different in regards to your patient interactions?
Since I have the mic, I set this up. So my day-to-day life varies incredibly day to day, even half day to half day. So as being faculty in our residency program, I spend about a third of my time in my own clinic seeing patients, about a third of my time precepting our residents and medical students, so they rotate through. And then another third of my time is doing various administrative things from program side of things with curriculum development and making sure residents have everything they need to graduate. So depending on the half day, I might be in clinic seeing patients, or I might be overseeing residents. For me, probably the things that make my daily, like my own clinic, unique, about every third clinic that I do is more of a osteopathic manipulation day. So that whole half day, I see patients just for head to toe OMM and work on them. In my other clinics, I see everything from newborns to 100+ year olds for general primary care. But I tend to at least about 2 patients every half day have some sort of specific MSK reason that they are seeing me, either being my own patients that I've followed for a while, or people that come in through the community or from the other faculty and residents panels for injections, or just a more thorough MSK exam if it's, you know, knee pain that doesn't seem to be responding to the initial treatment type stuff.
So before I left the residency practice, I did things very similar to Dr. Beach, except more on the women's health focus, less on the sports medicine, because that's definitely not my niche area. Now in ED observation, I am employed as a 0.8 FTE, so not 100% full-time, which basically works out to 23 shifts per a 10-week block, because I work from 6 to 5 when I'm there, roughly. So it's early days. But I also get out at a reasonable time for my kids, and I'm a morning person, and it's honestly ends up being like 2.3 shifts a week, so it's not too bad. I basically round on the patients, supervise the ACPs, admit new patients, work with some awesome specialists, particularly our geriatric team, because our observation unit under the leadership has really done a great push to take excellent care of geriatric folks when they get admitted to the hospital. And the benefit to what I'm doing now is I have no clinical responsibilities when I'm not at work. So I don't have any patients that are my own patients. So no prescription refills, no phone calls, anything like that when I'm not actively working, which actually my husband and I run a nonprofit on the side. So that frees up some time to do. I do a lot of grant writing for our foundation and things like that. So it's a very nice balance. And I'm also able to have a lot of flexibility with my schedule for things like cross-country state championships or in the middle of the week. So I just asked for that day off. So it's been great for the stage of life that my kids are in at 10, 12, and 14 right now.
Okay, so currently I am a faculty member in the residency program as well. So about 75% of my time is clinical, and about 25% of my time is administrative. Of that clinical time, about half of that is overseeing residents, so precepting, and the other half of that is clinic time for me. And my clinic time is mostly lifestyle medicine focused, so that I have a little bit of a small patient panel that I follow. And then I also, like, if I have a lifestyle clinic day, and somebody cancels, they'll fill in with acute care kinds of things, so I don't have an empty schedule. So I do have a little bit of that worked in, but the majority of my time is seeing patients for consultation. So people are referred to me from either within our practice or within our whole department. So I get people from all over the family medicine department at Carillion, and they come to me usually with multiple medical problems in addition to weight, although not everybody has a weight issue. They have other medical problems, diabetes, high blood pressure, high cholesterol, heart disease, and they come because they want to focus on how to manage that with lifestyle. So we have a 40-minute intake visit where I do a deep dive into all of their lifestyle behaviors, and we do goal setting and education, and then I see them back in follow-up. I have shorter visits for that. They're standard 20-minute appointments for follow-ups. And so I see the majority of my time is doing that right now. And then I oversee residents. I also oversee, we have a residency, lifestyle medicine residency curriculum, which is built into our residency program. So our residents who are on that track can, at the end of it, when they complete all the requirements, they can be board eligible for lifestyle medicine as well as family medicine when they finish. And so they work with me one-on-one in my clinic and as well. So some of my residency oversight is directly with lifestyle medicine, and some of my resident oversight is just regular medicine clinic.
I'd say some of the joys and challenges of my days and weeks are variety. So every day for me is a little bit different. I do some inpatient consultative work and working alongside EDOPS providers like the likes of Dr. Perkins, and on Mondays and Fridays where I can do some inpatient work. And usually we get consulted as geriatricians for things like polypharmacy, frequent falls, delirium, or someone who may have existing cognitive concerns and comes in with new behaviors that family need help navigating. On Tuesdays and Thursdays, I'm in my own primary care panel of patients. So I have about 300 patients that are under my care. So I get to see them and build relationships with them and manage their chronic health conditions and concerns. And on Wednesdays, I work at the Center for Healthy Aging, where we do cognitive testing, do a lot of dementia care, dementia diagnoses, and sort of work as a safety for folks with cognitive issues who may be having other behavioral concerns or changes or need navigating sort of next steps with their cognitive issues. And then I work as the Geriatric Fellowship Program Director as well, so I have some time allocated for admin for that. And then I am the internal medicine geriatric experience. So the internal medicine residents rotate with me most weeks out of the year. So I'll have at least 1 or 2 residents rotating with me to get experience in geriatrics as part of their required experience. So I get to do every day's a little bit different, every week's a little bit different, which I really enjoy.
Mean generation. So we sit around and do over at TSG. A lot of variety, but a lot of time with the computer. So currently I'm 90-10, 10% clinical, which is 1/2 day a week. I see patients in the family medicine office as on a walk-in basis. I don't have my panel. My partner, who is also board certified in clinical informatics, he has kept some of his panel, so he sees some continuity patients. But most of my days are more in a leadership role. So working with the application analysts, the computer programmers who are programming Epic, if you will, helping them understand the clinical implications, the clinical workflows. I lead the clinical decision support stewardship committee. So all the best practice advisories that pop up when you're using the electronic health record, we oversee those and try to make them as frictionless as possible. We haven't done a great job in the past, but we're getting better. I also oversee all of the order sets, both in the outpatient and the inpatient arena, making sure that we're providing evidence-based care through the use of those order sets. And epic upgrades, so the electronic health upgrades, have one coming up here soon. So all of the changes that are coming with those, helping the educational groups get education out to the providers, to the nurses, to basically everybody who uses that. And one of my pet projects right now is the use of what's called DAX, or Dragon Ambient Experience, which allows providers to go into an exam room, set your iPhone down, press a button, the machine records everything that is said in the room from everybody that's there, whether there's an interpreter, children, etc., and then takes all that information and writes a very nice progress note, which is amazing. So I'm very impressed with that.
I think this is something Dr. Speakers alluded to a bit, but how has your subspecialty changed over the course of your careers?
When I came out of residency, we didn't have a subspecialty in clinical informatics, and so it really has developed. It's exploded. The board certification, the fellowships that have come with that, the implementation of the electronic health record across the U.S. Really has grown out of its infancy and continues to grow.
I'd say for me with geriatrics specifically, so I've been out of fellowship for 6 years now, and in that time there's been a few changes, one of which is, especially specifically to our group, is a shift from where traditionally geriatricians had been housed in nursing homes. We've sort of shifted from that model, our group specifically, to do, again, more of the inpatient care where we feel like we have maybe more value in that space and can reach a broader net of individuals and have a bigger impact for older adults. So we've sort of stepped away from the world of subacute care and from nursing home care. There are still geriatricians who work in long-term care facilities. That is still a path for geriatricians, but I think that's becoming a slightly less common. And more specifically to the memory care aspect, there's been a lot of new changes in dementia care, both in the diagnosing of dementia and Alzheimer's dementia, including a lot of new lab and blood tests, which we did not have access to when I finished fellowship 6 years ago, and a lot of new nuanced treatments, which we haven't fully adopted because of a lot of reasons that I could go into in a different talk. But there's a lot of technologies going into dementia care and dementia treatment that are new and novel and exciting, I think, for the future of the care of those individuals.
So the specialty of lifestyle medicine started up around 2005. I'm getting ready to go to the annual conference at the end of this month, which is our 20th anniversary of being a college of lifestyle medicine. So, and it started out as a pretty small kind of grassroots effort. Actually, some people from around here were sort of instrumental in the beginnings of it. There was a Dr. John Kelly who practiced down in Franklin County, and then he moved away, but he's one of the founders of the American College of Lifestyle Medicine. So we have some local ties to here. And the college has grown tremendously since it started. It is growing exponentially in membership. I don't even remember the number now. It's well over, it was over 5,000, like 5 or 6 years ago. I've lost track of the number. When I sat for the board exam in 2017, so since it started, it's become a college. It has a journal now. It has these annual meetings, which are getting bigger and bigger, and they're selling out, 3,000-4,000 people at these meetings. And then there's a board certification that became a thing in 2017, wasn't a thing until 2017, and that's when I became certified. The residency curriculum has become a thing since then. So it's grown a lot. When I sat for the boards, for the first year, there were 200 people. And this year, there's over 1,000 sitting for the boards this year. So it's growing rapidly. And it's really about, like, how do we get to the root cause of what's causing all of the chronic disease that we're managing all day, every day. So there's more and more interest and engagement, and residents and medical students and patients want to know about it. So it's becoming much more and more popular as time goes on.
So for family medicine with OB, I graduated residency in 2006. And then I practiced at a hospital where it was a little challenging to navigate the relationships with the OB department. And then came here in 2012, and we had and have a wonderful obstetric department here, and joined a group which at our height, we actually had 5 family docs, part of our residency, doing obstetrics, including 2 who were C-section trained. And I did not do C-sections, but I would personally have years where I would catch upwards of 30 babies. So that didn't include the patients that I labored and then transitioned to a colleague, or the patients that went to C-section. And that was a very enjoyable part of my practice. Unfortunately, the pendulum in our area has shifted to less patients coming to family medicine for obstetrical care, more patients being significantly high risk because of morbid obesity, diabetes, chronic hypertension. It's hard to find a low risk obstetrical patient these days. And we also, unfortunately, over time, lost faculty members who are interested in doing OB. So that was honestly a big push towards me deciding to try something different for my own career path, because I kind of saw the writing on the wall there. And now our residency program is not considered to be a high volume OB program. So I see obstetrics probably eventually leaving the purview of family medicine completely in the next couple decades.
So for primary care sports medicine, one of my mentors Gunnar Brolinson, who's down at BCom in Blacksburg, was one of the founders of primary care sports med. So that was kind of in the late 80s, early 90s, and similar to some of these guys are saying, as far as going from a small group to a unified group to a board certified board certified organization. It's grown rapidly. I think the osteopathic side of things has grown, but maintained kind of like a fun, close-knit group feeling. So when you go to national conferences and things, it still feels very very much like a reunion every year. Most of the people there. On the allopathic side of things, it's very large and has grown rapidly. And not to, both of them are great. They're both fun organizations to be a part of. They just kind of have a little bit of a different feel. The osteopathic side of things is just always kind of in some ways tried to maintain that close-knit group feeling, which is a big enjoyment for me, as being part of that college. But yeah, it grows rapidly. I think now when people look to sideline coverage and especially with the enlightenment of treating concussions appropriately, that it really gets looked to more to primary care sports medicine rather than orthopedics. Even a lot of our orthopedic colleagues will say, well, what am I going to do on a sideline? It's not an OR, so outside of maybe, popping a shoulder back in place or something, a lot of the things that really go on acutely on the sideline is not the things that they do on a routine basis. So a lot of what we're really trained in from a primary care standpoint are the things that need acute management on the sideline and stabilization before they potentially need to go to the OR later on. And some of that downstream follow-up with the concussion management stuff. Primary care is much better suited to maintain all of that than orthopedics.
Oh, yes, questions.
This one's for Dr. Reynolds, specifically sort of adding on to the trend of where you see geriatrics heading. How much time do you spend with each of your sort of panel of patients? And how do you see that amount of time changing in the future?
Yeah, it's a great question. So right now,
Repeat the question.
and to repeat the question was about the time that I'm allotted as a geriatrician to see patients within my specific panel, and how I might see that changing in the future. And I've had the luxury of having a small panel of patients and follow-up visit I get 30 minutes. In new patient visits, I get an hour. And I'm slow. Everything in geriatrics moves just a little slower. There's a lot of complexity within the visits, both from their own medical issues to the social issues and other things that need to be addressed in a 30-minute time frame. So we get as much done as we can, and I'm seeing people back pretty frequently, often on 6 to 8 week intervals to see people back, which you know, I don't have a lot of people where I'm saying bye, see you in a year. So I'm seeing people more closely, and the institution has been really wonderful about allowing me to have a small panel size, because I think that's necessary. And the memory clinic, in the panel that I see, same equation, 30, I joke that the new, we have 30 minutes for follow-ups, an hour for news, and they all take an hour and a half, no matter what it is. And that's just the way it is. And, but I only have 4 patients in a half day that I see in the memory clinic, so it's plenty of time to kind of get through. It spills a little bit in the afternoon, but I have administrative time sort of built in to buffer that. And that's just what it takes. You have to have time. It would be impossible to have sort of a 15-minute office visit to navigate all the things that need to be navigated in that time. So I feel blessed to have that time. And I think that that's catching on as the population ages, that, you know, in order to address all of the concerns that need to be met, to make sure we're not having older adults ending up in the emergency room as sort of their next steps in their care, we need to build in the time ahead of time. So, great question.
Go ahead, Camille.
I had a question for Dr. Polk. I'm just wondering, so with all of the the rise that we're seeing with chronic diseases and metabolic syndromes, people are kind of like turning to different areas or like to try to build up their like toolboxes. And so I'm kind of wondering for you, if you could talk a little bit more about what is lifestyle medicine, like what are some of the things that you do or different tools in your toolbox, and then also how it might be different from like functional medicine or like integrative medicine, or if there is overlap in those areas at all.
Sure. Yeah, so lifestyle medicine divides the pie, I guess, into 6 different pillars. So we talk about nutrition, exercise, healthy sleep, stress reduction, social connection, and risky substance use. So what do? I do a lot of discussion with them as to where they are with each of these areas in their life, and then we talk about how to address each of them individually. So it's sort of the big picture recommendations around diet being, you know, high fiber, plant strong, low processed foods, that kind of stuff. And then I kind of drill down into, okay, what are you willing to do? And so we set goals specifically around those things. The difference between lifestyle medicine, integrated medicine, and functional medicine. So lifestyle medicine, I think, is at the foundation of all 3. And if you look at across the board at all 3 of those areas, we all talk about basically the same principles with some nuance. So depending, functional medicine has a little bit different take on nutrition than lifestyle medicine, but it's essentially fundamentally the same. Integrative medicine adds some procedures and things that lifestyle medicine doesn't do, like acupuncture and some other things along that lines. Functional medicine gets into a lot more laboratory testing and supplementation, which we do routine laboratory testing and, you know, looking for deficiencies and things like that, but and do some supplementation in areas that are pretty straightforward and commonly accepted as evidence-based. And functional medicine tends to interpret labs in ways that are different than the way that traditional medicine interprets labs. Does that mean they're wrong? I don't know. I don't know what they have some data to support it. I'm not sure how confident I am in their data. So lifestyle medicine really tries hard to stick with what we know is evidence-based. And the other areas kind of stray outside of that a little bit. It doesn't mean they're wrong, it just means they're different. But as far as the fundamental principles, they're the same.
Can I ask a follow-up question to
Yes,
that?
please.
Okay. So what do you end up like prescribing? Are you like making suggestions, like solely lifestyle recommendations, or what are you also?
Solely lifestyle medicine, so lifestyle prescriptions. So I prescribe diet, exercise, sleep. So I prescribe, you know, go to the gym and lift weights twice a week and do these kind of exercises and, you know, do cardiovascular exercise this many minutes, and we negotiate all those things. Same thing with food, you know, I'll prescribe eat 3 vegetables a day, you know, things like that. You would be surprised at how many people's lifestyles are so far away from that, that even just hearing somebody say, eat a piece of fruit a day is like a big deal. So yes, we treat lifestyle as medicine. And it is as powerful and as potent as many of the medicines that we prescribe. And so we treat it like a prescription. So they come out with a whole list of recommendations that they do, and we modify that over time depending on how successful they are with that.
Thank you.
Austin, would you like to go ahead with your question?
Yeah. Oh, this is also for Dr. Polk. Sure. I'm curious to know how you deal with insurance and like coverage, and if insurance doesn't cover it, how do you work with uninsured individuals or
Yeah, so it is covered by insurance. Most, like I said, people I see have multiple medical problems. And so I bill based on problems, just like any other office visit. And I bill, there's also ways to bill based on time. And so for my initial consultations, they're based on time. And so I don't have any problem getting covered.
Okay.
As far as uninsured, they're covered, I mean, in our practices, we have, you know, patient assistants and things like that, that they would, just like they would be covered for any other office visits, no different.
Okay,
Yeah.
very.
So my question opens it back up into the panel, but you guys have all started in either family medicine or internal medicine, and your paths have diverged pretty substantially from each other. So what would you say kind of through your experience or through your journey in medicine led you to the specialty that you're in? And how would you use that to sort of counsel new people entering the field, you know, if they were curious about your subspecialty?
I think for me, similar to, I think probably what a lot of you guys will go through, is you rule out the stuff you don't wanna do first. Like I knew I couldn't be a surgeon, maybe because I'm 6 feet tall and all the blood goes to my feet and I pass out in the operating room. So that didn't work out real well. And in psychiatry, I have a tremendous amount of respect for psychiatrists, but you get a lot of psychiatry in family medicine, and I don't think I could deal with the severe mental health issues that our psychiatrists deal with. So there are things that I already checked off that I did not want to do. And then I just really enjoyed kids, but I also enjoyed the women's health component. So that's kind of how I came to family medicine. Just with the combination of being able to do a little bit of everything, because I do like to talk to adults as well and not just small children all the time. So that's kind of how I came to family medicine.
I went to medical school because Governor Rawlinson told me to go to medical school and be a sports medicine doctor. Which is kind of true, but also, I truly did though. I was going into medical school to be primary care sports medicine. It's the reason I picked the med school I went to, the residency, the fellowship, everything. I would say that my advice would probably be to keep an open mind to other things. I think I was lucky enough along that process to have some very good mentors and preceptors who pushed me a little bit to entertain other ideas along the way. I had like a brief 6 months of insanity where I thought I was gonna be an OB. Then I realized I don't like that at all. And then I fought with her for 3 years in residency of trying to get her to deliver every patient that I was supposed to. So it was a good turn of events there. But I entertained it for a few months, did a couple audition rotations, realized I didn't want to do it. And then en route to fellowship, I had some of the faculty at our program kind of make me pause and say, you know, you're actually pretty good at the family medicine part of this too. Maybe you should think about that. Maybe you should think about teaching. And I felt like I needed to see it all the way through to go to fellowship, and because I always thought I would be Division I or professional team physician. That's all I ever wanted to do. I got there, life had changed. I was married, I had young children. I didn't really want to go travel and stand on the sideline of somebody else's kids' sports. I wanted to be on the sideline of my own kids' sports. So being pushed to look at things from other point of view and not being afraid to take a step back from the original goal that landed you where you are now is probably the best advice I can give. I think there's a lot of regrets if you don't see it through, but also potentially if you ignore a lot of things on the way. So just always kind of checking out and seeing, do I still want to do this? Yeah, okay. Good forward.
So I ended up in family medicine because I liked pretty much everything except surgery. I thought I wanted to do OBGYN and I realized I didn't like surgery. So that's a big part of OBGYN. So I decided to do family medicine because I could deliver babies and I could keep doing hospital and all the things. So I did that I did OB for the first 5 or 6 years of my practice. I did inpatient along with outpatient for up until 2011 or 2012. Got out of that then. And the one thing I've always liked about family medicine is that it's very versatile. I mean, you can do lots of different things and stay within the family medicine umbrella. So, in order to keep myself, I guess, engaged, I did other things along the way. So I did, hospital administration kinds of things. I was chief of medicine, chief of family medicine, chief of medicine on the exec committee of the department and all those things for a number of years. And then segue from there, I was the clerkship director for VTC for the first 7 years of the clerkship. I did that and then stopped doing that and started doing lifestyle. And so there's all kinds of ways you can flex within family medicine and do different things and keep yourself, your mind engaged and active and happy. So yeah.
Having started my career in introduction to patient care as a certified nursing assistant in a long-term care facility at age 16, I would not have said I would have been a geriatrician 20 years later, but and it wasn't a bad experience. That wasn't the path I had made for myself, but I knew internal medicine coming out of medical school was the best fit for me. I wanted opportunities for specialty care sort of after internal medicine training and actually fully intended to do pulmonary critical care after entering into internal medicine. And then priorities shift at some level. You start to think about, what you want life to look like outside of your day-to-day, your work life. And I wanted something that had high job satisfaction, that had a nice work-life balance. And I liked having the specialty designation because it afforded me a lot of flexibility in my roles. And so geriatrics was a great fit. There are not a lot of vulnerable adult populations there are, but there are not a ton that we can work with, but geriatrics is one that certainly needs the help. And there's tons of opportunities to do research and growth in academics, and I can do teaching, and I can sort of be the person within our internal medicine group who people can ask questions to as well, or send me patients that they're puzzled about, or older adults who need sort of an extra helper hand or someone to overlook things. So I liked all of those aspects of it. And I get to work Monday through Friday. I don't have weekends or calls, and I'm done by 5 p.m. on most days. So I like that I can also have a life outside of what I do. I love what I do, but I also like life outside of what I do. And it afforded me the perfect amount of flexibility and job satisfaction.
Where to start? My undergrad was electrical computer engineering. So as I was finishing up, you all have seen The Big Bang Theory. That's what my life was like, and I don't want to continue to be a geek for the rest of my life, and so decided to go to med school. Of course.
Here we are.
But I was going to go to med school with the intent on doing neuroscience and true virtual reality. The MRIs and some of the functional MRIs had just come out at that point, and we were doing some really cool stuff. And so I was like, well, if you can read from the brain, you can write to the brain. Finally starting to get to that point now. But on my way to med school, I spent a summer as working in a free health clinic in Morgantown, West Virginia. And that was the pivot into primary care. So went to med school with the thought that I was going to do primary care. Did my residency thinking I was going to do primary care. And as I was finishing up and starting to ask the question, where am I going to go and work? As you've heard from others here, the lifestyle obligations. My wife said, we're not leaving Roanoke. My choices got small quickly. And at that point in time, we had our residency director kind of reached out and said, hey, you have this computer background, you know this computer, we're working with this electronic health record. Why don't you do an informatics fellowship and help us with some of these things? And I was like, okay, the universe just kind of pushed. And then from there, it just changes here and there. But I will say that the background in family medicine makes the conversations very easy. So if I'm working with my surgical colleagues, I've been in the OR, I understand pre-surgical, I understand surgical cases, I understand post-surgical care. I've delivered babies, so I can have conversations with my OB colleagues. Done rotations in the ED colleagues as well. So we, in family medicine, we have that breadth of knowledge so we can have those conversations and understand where others are coming from. So it really helps.
All right, so I'm gonna ask a couple more of our kind of general questions, and then we have some deeper questions that were asked by our students. So I'm sure they'd love to hear your thoughts on those, but before we get into the deeper questions, pros and cons about each of your jobs. What do you think is a unique reward of your specialty, and what do you think is a unique challenge?
Easy, the rewards is the flexibility. So much like Karen, I have a lot of flexibility. If I need to take a day off, as long as it's not my clinical day, I can flex if I need to come in late, if I need to go home early, have a lot of flexibility. One of the cons is some of the leadership discussions, saying no, bringing focus to the organization. So when a clinical chair says we need to do this thing, I need to go have a conversation and say, no, there's some political capital that gets involved. And so those discussions are oftentimes very difficult.
Pros for me, I have some of the funniest stories about patient interactions, and just things that people have said to me during patient care that I have a whole mental catalog of all the funny things that people have said. So it really is, again, job satisfaction is my pro, because it really day to day, I feel like I've done something meaningful and come home having felt good about what I've done. The cons are probably like a lot of things that can happen in primary care. We still use fax machines. That's a thing. I still have a lot of faxes come through. So paperwork is challenging. I think in a lot of ways, the computer system has made things easier in terms of documentation and accessing information. It has made us as providers very accessible as well, which is good in a lot of ways, and which is challenging in a lot of other ways through patient messaging and things like that. So there's more real-time communication, which is great, but it is something that we're always doing in the back of additional patient, upfront face-to-face patient care as well. So we balance sort of the pros and cons, and I think a lot of new technologies that are coming out are making a lot of these things easier to manage, and I think will continue to make things easier to manage.
So the pros of what I currently do with lifestyle medicine is I actually see people get better, which is a beautiful thing. People come off medications, which, I love deprescribing. So that is something that I enjoy a lot. People feel better, like they come in, they tell me how good they feel. I mean, that's a huge shift from what I would say was standard primary care days, for me. I would say the cons, I walked away from a lot of the cons when I walked away from my other practice, which was huge. I was in, like I said, regular family medicine practice. I had a panel of 3,000. So you had a panel of 300, a panel of 3,000. That's a lot of work. And so I let that go. So the cons of the paperwork and the administrative time and all that, I don't have that anymore. So it's hard for me to say. I can't really honestly think of a con, to be honest. What I do right now, I love educating residents. I love seeing the patients. I'm just having a blast right now.
I think, I'm not crying, I just got like a frog in my As far as pros right now, I think it's schedule. A little bit of the con too is the same thing because I have to start at 6, which is okay for me, but sometimes if it's like my 4th day in a row, it can get a little bit old. And I do work some weekends, but it usually ends up only being like 2 weekends to 3 weekends out of a 10-week block. So it's not bad. My colleagues are pretty nice to me. I don't really have to work any evenings, so that's good. I think one of the things that has been a little easier coming from the residency is during the residency practice, we had 30 residents that we supervised. So they transition over because they should, because residents advance and graduate. So sometimes working with a variety of people at different skill levels as a supervisor can be challenging. Here I supervise probably a core group of like 6 to 7 ACPs. So I know them, I know who's more thorough, but I know who will dispo people quickly, but I also need to double check their notes to make sure that they're not dispoing somebody who shouldn't be dispoed yet. So it's a little easier from that standpoint because you get to know your people a little bit when they change over less and there's less of them to manage. I think in primary care, I have a tremendous amount of respect for people who do outpatient primary care because I would find even on my days off as a primary care physician, I would spend an hour and a half, 2 hours on my desktop answering messages, prepping charts. I don't have that part of my life anymore because I'm just practicing as part of the emergency department. So I get paid as an emergency medicine physician. And then if I have a day that the service just blows up and I have to stay a couple hours extra, I just tell the schedulers that I stayed a couple hours extra and they just pay me for those couple extra hours. So that's a nice benefit to the job that I'm working now. Also, I love working like with the consultants. I love learning from the geriatricians. I never realized how many people had ENT issues until I did OBS. Like I see the ENT team like every time I'm there. So learning from their expertise, from ortho, from the cardiologists, like just on a regular inpatient basis, kind of seeing what's kind of new in some of the specialties and how they're managing some of these problems. That's pretty cool to just kind of see that in real time too as well.
I think for me, the pros are that family medicine in a faculty environment suits my ADHD soul fairly well. Every half day is literally something different. I get to use my hands a lot, which I enjoy doing. I enjoy teaching residents and kind of watching them figure out not just medicine, but life. I'd say the cons is probably also the residents. We love you guys, we love who you turn into, but there is a lot that goes on in the background with managing the ACGME and check boxes and administrative things to make sure that that goes as smoothly as possible, and a lot of turnover and transition, and which are good things, and that's supposed to happen, but is a lot as well.
So we're coming into the tail end of the hour, and I do want to hit some of those deeper questions, so that way our friends at home can have them answered. But Josh and whoever else in the audience wants to ask a question, please go ahead.
Yeah, so some of you guys have alluded to this in your answers, but the business of primary care and kind of how that's evolved and influenced you in your career, where you see that going and things you think new medical students should be aware of in the primary care field?
Learn it, not ignore it. I think, all jokes aside, I think primary care is one of the few specialties in medicine in general that continues to just like hang on to this idea that we should be here for the good of all people and not to get paid. But at the end of the day, you put a ton of time and effort and money into getting out of residency, medical school residency, and you should be paid for it. So learning how to do it effectively and efficiently and to be able to maximize your time while you're in the room with somebody and get paid for the outcomes that you're doing. Don't worry about it. It's part of the job.
Any of you guys wanna? I don't bill anymore, I mean, the hospital bills, and that's one of the beautiful things about New Zealand is, since they're a socialized medical system, you document what you need to document, you don't document for billing and you don't bill. So it makes it easier because you don't have to worry about billing and coding and things like that.
A change that happened, and maybe it was you all, I know better, I came from the VA system initially and I didn't have to think about billing and RVUs and things, it was just built in. But there's a time-based billing as well, which is wonderful as a geriatrician, because that's often there's a lot of medical complexity, but the time aspect is what I'm billing the highest part of. And it doesn't affect my bottom line necessarily because I'm salaried, but it matters for the institution to get reimbursed appropriately. And most of my billing is through Medicare and their supplemental programs. It won't, it's not something that'll go away. It's good to have, I have a very kind of a base knowledge, and that's all I've needed to sort of get by, and that's worked well for me. I do want to put a plug in for, you've probably heard of things like public student loan forgiveness and things if you're working in academics and things. And I'm a product of successful public student loan forgiveness. So it can happen where I think a lot of pull is towards a more lucrative specialty, thinking, well, I need to pay off these student loans. And I hope that there continue to be programs like that that incentivize working in academic centers, not-for-profits, so individuals can pursue their passion in primary care as well. And I think will continue to be a push for that. There'll be a big need for more primary care providers moving forward.
So I agree with Dr. Beach. Learn it, but the business of medicine is one of those things that it's kind of the dark side, if you will. That I think here in the U.S., putting my kind of that personal hat on, that I think we could do so much better. When I look at the way we bill, where the money goes, the contracts, all of those pieces. When I start to think about it, I get really frustrated and irritated. So I try not to think about it too much. I learned how to bill so that I can get paid for what I do, and it really can be reimbursed for the work that I do. But when it comes to just that machine that's rolling on, I don't agree with it.
Awesome, go ahead.
Okay, this is kind of going off Josh's question as well, but I previously worked before I came to med school in value-based like Medicare primary care, and I was literally called a clinical informatics specialist. So my job was like knowing how to like bill all this stuff and do whatever. But I think that I experienced a ton of moral distress while I was like working and doing that, and it makes me a little bit sad to kind of just think about, oh, like I'm just gonna have to accept how this is, and like you guys are saying, like it doesn't make you happy, but like that is how you have to work. You have to work within our system. Have you ever thought about like possibilities of changes that are possible to make within what we're doing, or like actions that can happen that can help to like mitigate those contrasting interests? Yeah.
So the answer is yes.
Okay.
Have thought about it, but in order, at least for me to start to make that difference, I would probably need to be in a different setting, right? So if you're working as an employed physician for Carilion Clinic, there's my perspective, there's not a lot of change that you're going to bring, but certainly there are models across the U.S. There are people that have done some amazing things. Back when I was in residency, there was a practice down in Texas where the woman went to time-based billing out of pocket. It was $3 a minute, and that's what you paid plus some other things. So there's some other models out there. When you start to roll insurance and third-party payers, and it's where it gets sideways, and yeah, I don't have an answer for that.
Sorry, that was a really broad and like kind of
It's okay.
question.
Oh, without.
So I think one of the things that I would love to see happen here is to somehow become a climate that is less risk averse, probably less malpractice. In ED obs, I've been asked to admit things that really don't make rational sense to admit sometimes. Like, for example, a lady who'd been watched after a car accident for 10 hours and had a small pneumothorax and was breathing fine and sat in 100% of room air. And that's not standard of care to keep her overnight. The most expensive test you can order for a patient in the hospital is an admission. So I just talked to the trauma team and said, hey, she doesn't want to stay. I don't really want to admit her. And they're like, okay, we'll do another chest x-ray now instead of keeping her overnight and doing one in the morning. Even my husband and I have had these same discussions when he's admitted patients to me from ED ops. And I said to him, you know, this wouldn't be admitted in New Zealand, right? And he's like, oh, no way it'd be admitted in New Zealand. But we're not in New Zealand anymore. We have lawyers here. And he is actually not, he does not practice defensive medicine. He's internal medicine trained as well. So he practices smart medicine. But there are certain decisions that we make in healthcare because of the nature of the litigious society we live in. So having practiced abroad, if there's anything that I could bring here is just the ability to practice evidence-based medicine and not worry about am I gonna get sued?
I know we have other questions burning, so not to derail us too far, but I think while there are lots of other models that exist out there in the world as far as other payment plans and things that could potentially happen, in talking about moral distress with that, I think a lot of that continues to broaden the haves and the have-nots. Like a lot of the DPC type models, unfortunately, I mean, you have to be able to pay for that, right? So I think trying to check in with what really it is that distresses you about billing insurance companies. In my opinion, if it's concern for the patient, if you're talking about models like this, where hospital systems that are nonprofit are supporting people who can't pay for things and have assistance programs and things, it is fraud to not bill fully, just as much as it would be fraud to purposely overbill. So, my opinion would be, where's, like Dr. Speaker was alluding to, where the money goes doesn't make any sense, right? So, bill and maximize the person's benefits as well. So stick their insurance with every penny that you can, because they're paying for it. And, those things are there for a reason. Maximize every benefit that they can get. And if you learn how to bill appropriately and use the right codes and the right terminology, you're actually continuing to shift that and push more into the insurance and less in your patient's pocket, out of your patient's pocket. So there's ways to get around the moral distress of that.
Thank you. That was really.
So we're coming up to the end of our hour, but we do still have a couple of questions. Physicians, if you wouldn't mind spending another 5-10 minutes with us, we sure appreciate it, but absolutely no worries. We want to be mindful of everyone's time. It's a hard question. Yeah, it's a hard one. Actually, along the same line, talking about DPC, concierge care, right? These different styles of practicing medicine, right? Do we see any room for those to grow or change, or how do these different types of practice, how do you view those expanding or changing over the next 10 years?
Yeah, I mean, I think that concierge medicine and DPC is going to be a large portion of the access to primary care in this country. My personal opinions on that vary on a daily basis. One of my best friends does a version of DPC and is set to make $1 million this year. So is it evidence-based medicine? Not really. Does that bother me? Yes. Does that bother them? No. Is that continuing, again, to give access to people who have a lot of money? Yes. Does that bother them? No. So there's a lot. I'm not saying it's right, wrong, different. There's some days that I'm like, look at my own life. What could I do for my family if I was making $1 million a year? So again, flip the coin every day when I wake up. I probably have a different opinion of that. But I do think that DPC and concierge medicine is not going anywhere. And it's going to continue to grow as there's different formats and access to it as it becomes more widely acceptable and there's different models. There are some models that are more accessible to people with not as high of incomes. There's a guy in Blacksburg who runs a DPC that it's very accessible. And for people who, especially that are self-employed, insurance is ridiculously expensive for them. So he actually has a model that probably benefits them to have more access to preventative care. So there are different versions of it, but it's going to explode.
My only concern about those models is widening an already existing care gap and sort of disenfranchising maybe a group of people. We'll always need to have safety net programs in place, Medicare and Medicaid and things. And hopefully institutions will continue to accept those insurers as payments, so we have options for folks. I agree that my opinion changes about it as well, and I think there's probably right ways to do it as well. Like it sounds like the individual in Blacksburg could do if you could, bundle payments to provide services at less of a cost than you might get as towards a bill from something that your insurance didn't fully cover, then that makes some sense. But again, just being mindful of how that could disenfranchise a large group of people.
All right, thank you all. Next question, for those of you who returned to a fellowship after being in practice for a while, what was that like? And what changed about your life in order to go back to fellowship and resume education? Like, yeah, if you've been practicing for a while, you return to fellowship, then less time.
I went right in.
Experience. I went right in.
I think we all went right.
We all went,
Yeah.
I think we went right into fellowship.
Disregard. All right, so we have one final deep question, and unless anyone in the audience wants to ask anything. Okay. What do you think is the most critical issue facing primary care right now?
So having seen two healthcare systems, I think it really is the disparity between the haves and the have-nots. I definitely think there are things that we have more beneficial with our system here, but as part of universal healthcare in New Zealand, what I saw is that everyone had access to something. I saw a concerted effort that they made to improve the healthcare of the Maori population, which is the indigenous New Zealand population. They are a bicultural nation. 20% of the people are Maori. They have across the board worse health outcomes with cancer, diabetes, hypertension. So they do things for them specifically. They have better access to GLP-1 agonists for diabetes. They have earlier colon cancer screening. They screen Maori folks at 50 versus New Zealand European at 60. They acknowledge, yes, we took over this country and we suppressed this population. And now 150 years later, their health is suffering and we're gonna try to fix it. So it's not a perfect system. They jump on cancer really quick. If you need your hip replaced, unless you have private insurance, you're gonna wait a long time. But I think the fact that there is something for everyone is something that I would like to see be more accessible in the United States, because I think medical bankruptcy is such a big issue here, or people not accessing care because they fall in that gap where they make just enough that they don't qualify for Medicaid, but they can't buy insurance. It's really tragic when people can't get access to Pap smear screening and things like that because they can't afford it.
I could probably spend another hour talking about the issues that are facing primary care in our country's medical system in general, but I think one of my biggest concerns is to second that is kind of the haves and the have-nots. That dichotomy just continues to widen. And truthfully, one of my biggest fears is we already have a significant there's not enough access to primary care in this country, like at the bare minimum, and we have a significantly aging population with a lot of chronic medical conditions. And as the cost of medical school continues to go up and the lack of reimbursement directly to your primary care physicians continues to stay stagnant, there are great programs out there, but it's still, it's something to think about. And there's less people going into primary care, even with, we still don't have enough doctors, let alone there's less going into primary care. And in speaking to a lot of physicians around this country, I also fear the mass exit from medicine is coming. It is happening, so that lack of access to medical care is bad already, and it's about to get a heck of a lot worse.
I agree with all of that, sad but true. And the other piece, in addition to the things that they mentioned, I worry about the health of our healthcare workers, and particularly the burnout situation. I mean, that's not unique to primary care. If you look across all specialties, burnout levels are high. And so, trying to figure out ways to really support what we do. So, Dr. Speaker's work with trying to make our EMRs more efficient and trying to eliminate the stupid stuff, which is, the stuff that really makes us frustrated throughout the day and takes the joy out of what we do, because so much of what we do is joyful. I mean, seeing patients and talking to them and being part of their lives is very joyful. And if we could just minimize the other stupid stuff, it would be much happier. in general, and there's a lot of that. And so, it's kind of sad to see people quitting what they do because they're burnt out or they're frustrated with the system, and we could make it a lot better. So, I think keeping that in the forefront as we move forward is important too.
Echo what's been said and would add that some of what I think is a concern for primary care is just the fragmentation of care, meaning everybody's got their specialists, they've got AFib, so they're seeing their cardiologist, and their creatinine's not perfect, so they're seeing their nephrologist, and they've got an inhaler, so they're seeing a pulmonologist. And it kind of leaves like, what organ am I paying attention to? But I do ask often to my patients is how attached you are to your specialists, because maybe we can simplify things a little bit and try to have less of all of the specialists involved, just to try to simplify and kind of keep care under an umbrella, because it can just be hard to navigate all that communication and nuance. But the biggest issue is the access to primary care, both in areas like Roanoke, but in rural areas as well, where there's just not as robust access to primary care, not as many providers who are willing to be in those areas. So that has a concern, and not as many people going into primary care as there need to be to help fill the need.
And I would echo that. I would also say relationships. So I think in primary care, we become very transactional. So I can, if I have something going on, I can go to the urgent care, I can go to the ED, I can get my care. But long term, I want that quarterback that understands me, right? That understands my blood pressure, my cholesterol, my family, what's going on in my life, so that if I have an injury or something that's occurring, they can pick up on some of the smaller pieces, and they know me, they know how I approach medicine. That plan that we put together and we come together is one that's tailored for me. And I think that we're losing that with the access and there. So we want those long-term relationships.
With that, I think that's going to conclude our panel. Thank you all again so much for spending the afternoon with us. If there's any other questions, please feel free to grab our panelists where they go. If you have to sign in, please do so. Sign in sheet by door.
And let me just say, Dr. Schmidt delivered my son.
Sutured the back of his head. And I sutured the back of his